right, let's get started. Good afternoon, everybody. Thank you so much for joining today. So during this special month dedicated to celebrating the LGBTQIA+ community, I warmly welcome everyone this afternoon to discuss the mental health dimensions of gender affirmative surgery by Dr. Virupaksha HS. So firstly, for those who are new to our expert talks, I'd like to just introduce the Green Oak Initiative. So we're a community mental health service. It caters to the needs of individuals who require psychiatric and psychological services that are easily accessible and affordable to the local community. It was initially founded by Dr. Soumya Krishna, the head psychiatrist at Green Oak, Dr. Ashleisha Bagadia, the consultant psychiatrist and head of family psychotherapy and perinatal mental health services, and Jwala Narayanan, who's the head of neuropsychological services. Just another initiative that we've recently started is called the Samartha, which is the low-fee clinic for individuals and families from the limited income background. So my name is Apurva Shetty. I'm going to be a moderator for today. I'm a clinical psychologist and a psychotherapist. I have been working with the Green Oak for about 2 years now. So I'm quite excited to welcome our expert for today's talk, Dr. Virupaksha, who is an associate professor at the Department of Psychiatry at Ramaiah Medical College, Bengaluru. He is a gold medalist in BPM Psychiatry, and he's also completed MD Psychiatry from NIMHANS. He has a total of over 20 years of experience in the field of psychiatry, and his main areas of expertise lie in transgender mental health, schizophrenia, neuroimaging, psychotherapy, and addiction. He is also a collector of numerous awards and recognitions across countries. Additionally, he serves as the external stress counselor for United Nations Department of Safety and Security, as well as a consultant psychiatrist at Indian Institute of Science. He is someone who shows immense passion, and he is a strong advocate for the LGBTQ community. And it's a very, very warm welcome to you, Dr. Virupaksha, today. Before we start, I'd like to introduce a couple of house rules for today. Firstly, the talk will be presented for about 45 minutes to about an hour, followed by another hour of Q&A. Now, what I would like for everyone to do is kindly mute yourselves during the presentation to minimize disturbance. Please feel free to select the option to raise your hand, ask any queries, make any comments if you want. It can happen during the presentation as well. He has been quite kind enough to say that he's happy to take the any queries even during the presentation. The other thing is, it would be very helpful if you could unmute yourselves, as well as turn your videos on if you have any query, just so that we all get to know you a little bit better today. But if you have any internet connectivity difficulties, then even the chat option is completely okay. Without further ado, I would like to ask Dr. Virupaksha to take the lead for today's much needed discussion. Yes, over to you, Doctor.
Thank you so much, Apurva, for that kind introduction. And it's always a pleasure to talk about something which is one of my area of interest, that is the gender and transgender mental health. And I would also like to thank Ashleisha and the Green Oak Initiative for having this talk, because what we see is generally people do not talk about these things, even though this is something which is very prevalent, very, very relevant in the current context across the world. The discussions about these topics, the challenges that are especially to the society and the healthcare professionals is something that is not addressed. So in that sense, I think it's an opportunity for all of us to interact, learn, and probably understand how things are. And I always would also like it to be much more interactive, and like how Apurva already mentioned, you can interrupt me in between if there are any questions. You don't have to wait for the end of the presentation so use the chat box, use the unmute button, and then please feel free to express, because here we are trying to understand and learn from each other. So what I'll try to do today is try to give a very brief overview about the topic, as well as how do we go about, what do we do, what's happening across the world, and also what do we do in Ramaiah. So it is, and today we are going to focus only about the transgender mental health and the process and the procedure involved there. So I'd not be touching upon other aspects of gender minorities. So the presentation will predominantly have the evidences that are currently there and certain things that as part of my professional journey for the last 10 years, I've been working in this field for the past 10 years, very regularly see transgender clients. So a lot of experiences are from interaction with this group who are very, very well aware, very tightly knit, and quite supportive and strong too. So if there are anything in between, we already have certain queries that you all had submitted during the registration. We will take that up also. And if there is anything else, again, feel free so that I can clarify as much as possible. So I'll share my screen. Can one of you please confirm whether you can see the screen?
Yes, we can.
Just a minute. Okay. So introducing the topic, many a times when we talk about transgenders, there is up till very recently, one of the aspect is also about people were not aware, not just about the concept, they were also not aware of the terminologies that we use. And most of my presentation will have a very strong content from WPATH guidelines, the World Professional Association for Trans Health, which is one of the largest organization of professionals who are working with the transgenders group. So predominantly it's called as Gender Affirmative Medical and Surgical Treatments, so GAMSTs. So I'd be touching upon all those components, including briefly about the criteria for hormonal therapy and what do we do it. Before we jump into talking about the content, there are certain terminologies. Again, most of us might already know how do we use it, but sometimes, this is not something that we generally handle every day. We might use certain terminologies interchangeably, and this is one area which is very, very sensitive to certain terminology. So I thought I'll just introduce those terminologies. We know that, and there was also, we are all aware of a very famous controversy that happened in the Supreme Court a few weeks back. So, and that is also something which is very important, that because we do not have the luxury of making those mistakes during our day-to-day clinical practice. So sex is a physical, biological attributes that characterize maleness or femaleness. So it is a biological construct, whereas when we talk about gender, it's predominantly a social and a personal construct. So it's socially constructed characteristic of women and men, such as norms. So what is the society think of, or what do you think about yourself? What are your roles, social roles, and the relationship of and in between groups of women and men? So it varies from society to society and can change. And that is also the reason why we see a huge amount of variation in terms of the evidence, in terms of the practice across the world. And if you look at just India, we are in Bangalore. We are very fortunate to be in Bangalore. Bangalore is one of the most accommodating place for transgender group. So it depends upon what society, how do we use those terminologies. So gender is predominantly a social construct. So gender and sex cannot be used interchangeably. Whereas gender expression or presentation is the physical manifestation of one's gender identity through clothing, hairstyle, voice, body shape, etc. So it's an expression. Especially this is something that we use in adolescent population. So one of the, again, least understood area in this aspect is about what happens in children, what happens in adolescent. So there we talk about more than just the gender, we talk about expression of it, because the concept of gender might not be very consolidated in that group. Whereas gender identity is one's internal sense of being male, female, neither of these, both, or other gender. One of the common probably question and the challenge that we face while we are interacting with our other healthcare professionals, or even including other mental health professionals, is sometimes we think that the gender identity is only you could be a trans man or a woman. It need not be like that. So it could be a male to female, or it could be a female to male, or it could be a male to neither, or male to or a female to both of those things. So we bring this aspect of fluidity, because gender is a concept of fluidity at any point in time, depending upon the person's internal sense, that can be expressed, and most of the times it is stable, even though we see very rarely that this keeps dynamically changing, especially if they are fluid. So that is something that we need to be aware of. Whereas non-binary, again, this is another concept. People uh, express themselves as non-binary, where the genders are comprised of more than one gender identity simultaneously or at different times. So there is a small overlap between gender fluidity and non-binary. They do not have a gender identity or have a neutral gender identity. They can have it, or have a gender identities that encompasses or blend elements of other gender. So again, I'm trying to use some more terminologies here: polygender, demi-boy, demi-girl, these sorts of things. So the thing that I would want all of you to appreciate is how dynamic and varied the gender expression and gender identity can be. And most of the times we should not be mistaking it as, okay, then does it mean that it keeps changing from one thing to another? It is not. They have a particular concept, they stick to that concept, and we see that consistently this being carried forward during their lifetime. So probably to briefly explain and summarize those things. So we have biological sex, we have gender identity, we have gender expression, and we have sexual orientation. One of the reasons why sexual orientation, again, even though it is not something which is the focus of today's talk, is many a times there is a tendency to misidentify or misinterpret sexual orientation as also gender identity. And sometimes the aspect of sexual orientation determining the diagnosis or the determining the transgender identity aspect. So gender identity is something where there is an internal expression of probably a male, female, other, both, or either. Gender expression is predominantly feminine, masculine, and others. It's just a physical expression or presentation of it. And we already know sex is something that is assigned at birth, and that is something that cannot change because they are determined genetically, including the aspect of intersex. And the fourth component is sexually attracted or sexual orientation. It could be a man to woman, a woman to man, both, or none. Asexuals are also something that we are seeing much more commonly these days. And romantically or emotionally attracted, that is again a psychological equivalent of sexual attraction. So when we talk about, in fact, one of the correction that I have made in this slide is this slide I had labeled it as prevalence. So, but again, like we have keep changing certain terminologies, because it is no more an abnormality. You can't actually call it as an abnormality or an illness or a disorder. So the terminology that is preferred is what is the proportion of population that has this gender dysphoria or gender incongruence. Gender dysphoria is something that predominantly used in DSM-5, and gender incongruence is something that ICD-11 is going to bring that terminology as gender incongruence. So most of the data till now had considered this as part of the psychiatric classification. So generally what we also see is male to female is much higher than female to male. In the proportion of 1:14,705 is adult male to female. Female to male is 1 in 38,461. When we bring in the aspect of non-binary, it's anywhere between 0.02 to 1%. And one of the disclaimer is most of the studies are clinic based. So real societal based or population based studies are something which are not really there. Most of the studies are also from Western population, from especially Southeast Asia and India. The studies are very minimal, where we do not actually have a real proportion of what is the amount of people who are living with gender dysphoria. So there has been a leap throughout the world there are efforts to make it or make it a non-pathology or make it normalization, right? Because it's a normal variation. So we have shifted from calling this disorder to dysphoria, which is destigmatizing and more accurate description, and it is also a normal variant. Generally, one of the way that I talk to my clients is I say that just like how we can all have, if there are probably 100 people in the room, 100 people have 100 different skin tones, we have 100 different hairstyles, we have 100 different body weights, body structure, body appearance. So this is just a normal variation of your gender expression. So it is not abnormal, it is not a pathology, it is not an illness, and it is not something that we really need to treat. But there is also a concept of why are the mental health professionals there, which I will address a bit later. So in DSM, in ICD-11, they bring in this aspect of incongruence, where there is something that is assigned at birth, something that you are not very congruent with. That is where the gender incongruence comes in. And there are certain criteria for children which are much more specific, and it is retained in DSM as an entity to facilitate access to care and insurance coverage. This is where most of the aspect comes in, even though health industry is predominantly driven by industry, pharmaceutical, this thing. One of the areas why the gender dysphoria or gender incongruence comes in here is this population, whether we like it or not, is under the vulnerable population, because the amount of support, the amount of awareness that is there in the society, the amount of awareness that is there in the healthcare professionals is also very, very minimum. So when they have certain comorbidities, there is a significant negative outcome. And that is the reason why the classificatory system continue to have these things in their listing, because that is one of the way to make sure that they take help. And they are decoupled from the sexual dysfunction and paraphilias, because sexual dysfunction is a disorder which has a specific treatment. Paraphilias are psychiatric disorders which have specific treatment, whereas gender dysphoria or gender incongruence is not a disorder and it is not an abnormality. The other component also is about the psychosocial component, where there are certain developmental aspect. Again, these studies, I should warn, these are from earlier days. Now we have certain entirely new set of data that is coming in, where some amount of parenting, some amount of developmental factors were considered as influencers to have certain gender identity, but they have very poorer evidence. The reason why I put this is specifically because there are certain situations where these studies are quoted as saying that, oh, there is an evidence that this can be something which is genetic. Again, that is something that is not proven because of the very poor evidence. Psychiatric morbidity. This is where the mental health professionals come into the picture, because we have a huge role in driving the awareness, in driving the interventions to this vulnerable population, and making them as normal as anyone else in the society. So there is a very high amount of psychiatric comorbidity, which is quoted at around 38% and 69% lifetime. That is more than 2/3 of the population with gender dysphoria can have a lifetime psychiatric diagnosis. Mood disorders are predominantly noted, 60% lifetime and 27% current. What we see in our setup is predominantly depression, non-suicidal self-injury, suicidal attempt, substance use, including psychosis. Anxiety disorders, 17% current and 28% lifetime. And what we also have seen is clients with gender dysphoria, the amount of comorbidity before their transition and after the transition, there is a great change in terms of the positivity. And I will also present data which is not published at a later stage. So 9% prevalence of documented suicide attempts in adults with gender dysphoria over a 10-month follow-up, 10-year follow-up period. And this is some study I think we can all refer to, where a huge number of clients, because of the poor support, because of the poor understanding and their own personal construct, they can have a very high suicidal risk. And that is also where as mental health professionals, we come in not just in screening for risk factors, and also to provide help and have the smoother transition. Specifically coming to role of mental health professionals, there are certain things that are expected from mental health professionals because the field is evolving, the the data is getting generated. Most of us might not have adequate information at all times with us to help this population. This population is also someone who require a very high degree of support and hand holding. So what we do? We get involved in terms of the assessment. Again, there are certain controversies about, oh, why should a mental health professional or a psychiatrist or a psychologist get involved if it is normal? The reason for that is there are certain other factors, including psychosis, including certain previous experiences, abuse, those things which might influence the way the person feels about their own gender. Probably I'll give one example, which I saw a year back. A very young girl came to the OPD, and she was referred by an endocrinologist. So she said that she needs to become a boy. And I said, we spent some time, and she said that I want to become a boy in a nutshell, because she was in relationship with another girl, and she feels that the only way the society will accept her to marry that girl is to become a boy. So, and she insisted for a letter, which was naturally refused, said she was offered help in other ways, but she refused to take that help. And a week later, she was sitting in the endocrinologist chamber with a letter from another person saying that she has got gender dysphoria, which is something which was not there. So in that sense, it becomes very, very tricky, important, and medico-legally very, very complex. Because the moment we assess, we will be able to rule out certain factors which might present as gender dysphoria, and support both to the client as well as the family. We always insist that even if the family is not in talking terms or they are not meeting, whether we could have a chat with your family over the phone. Can they come? So in the last 5 years, what I have seen in my clinical practice is more and more family members are willing to talk. They might not accept, they might take 5 years to accept, but they are willing to talk. So we need to bring in this aspect of, it is important to involve your family. It is important to educate the client who is been going through distress, and the family who has no idea about the distress, because the unique aspect of gender dysphoria is the person who is undergoing is very highly distressed, but the family will be shocked because they would not have anticipated, they would not have thought that something like this would happen. So in fact, I would say that family requires much more support than the client himself or herself. And we also facilitate the transition from the understanding, explaining why they feel like that, what are the different aspects to it, what are the different challenges that they might be facing, what are the experiences of other people. In fact, one of the most important brand ambassadors for improvement of transgender mental health is actually the people who have transitioned. And we have so many people in India and Karnataka that they are taking this educational aspect quite seriously, quite forward. And handling comorbidities, because the comorbidities, like I said, can be 1/3 to 2/3 of the population can have comorbidities, including as simple as anxiety, dysphoria, to as complex as multiple suicidal attempts, psychosis, and substance use disorders, aggression, suicidal and homicidal tendencies also. So we help them to deal with that, tease out what are the factors that is influencing, separate their gender dysphoria and the other consequences that can happen as part of their distress. And another important aspect is, as we progress, we also need to improve on the skills and training, because that is another aspect that is lacking in the current context. So professional requirement education, according to WPATH, they say that there needs to be awareness and acceptance. We still unfortunately see that a lot of healthcare professionals are not aware of these things. And there are instances where people have tried to do gender they've tried to say that you need to live the way that you're born with, and government of India, there needs to be a professional competency in terms of the degree and training, adequate diagnosis, training in both ICD as well as DSM, because most of the times when they are misdiagnosed, psychiatric diagnoses are lifetime. No one else is going to change it. In that sense, we should be doubly careful before making any diagnosis. Supervised training. Very less institutes handle transgender clients these days. So in that sense, someone, if there is an expertise, whether the other students, the other trainees are able to get the supervised training, knowledge about gender related disorders, CME and other exposure are the professional requirements and education that are expected. So the protocol that is generally recommended is the first step. Again, I will bring into the WPATH guidelines 2 or 3 slides later. There is a big change that has happened in the recent WPATH guidelines. So the protocol that is generally and something that is generically can be followed across is whenever the client approaches, if it is a general hospital, the client can come to any specialties, or if it is a specialty clinic, or if there is a psychiatrist or a psychologist, assessing the gender dysphoria and making sure that all other comorbidities are ruled out. There are no other influences, so that the patient is identifying himself or herself with a particular gender. So we also provide options of treatment. I can see that in the last 5 years, there has been a great shift again towards acceptance of hormonal therapy. 10 years back, every client who would come and say, I want a letter for surgery. And very rarely, probably out of 10, 8 would ask for surgery, probably 1 or 2 would accept hormonal therapy. But now we have changed it. The ratio has almost reversed. We have almost 9 out of 10 asking for hormonal, accepting hormonal, and 1 going for surgery, skipping hormonal treatment. That is because over a period of time, we have been discussing with the group, educating about the group about the positives of hormonal therapy, and that is something that has really helped, because they see that people are transitioning in a much better way. The dysphoria is much better. So treatment of comorbidities, again, this is something that will not influence the transition. Transition is something that happens parallelly, and treatment of comorbidity also happens parallelly. So it doesn't really impact the pace or the options of treatment. Information about the treatment and consent for referral. The sensitivity of the population comes when we use a wrong terminology, or also when we try to pathologize the whole problem. So it is always important to give all decision-making capacity to the client, and also ask whether they would like to be referred to someone else. We have had instances where clients have come and they said, why have I referred to psychiatrist? And they were offended. So in that sense, now we make it a point that you explain why you are referring, how that professional might help this client. If it is an endocrinologist, how the endocrinologist can help. If it is a gynecologist, how a gynecologist can help. Or if it is a surgeon, how a surgeon can help. So take the consent, sometimes document in the file, and then make a referral. So referral for hormonal therapy and referral for surgery, both in a common parlance, top and bottom surgery, or mastectomy, or breast reconstruction, or genital reconstruction, depending upon the transition, is something that can happen in surgery. It is always a multidisciplinary team approach. And the more people who are aware, the more support that we have, that is also something that really helps. And in Ramaiah, over a period of last 10 years, we were able to develop a team who are like-minded, who accept, who are completely fine and comfortable in working in this group. That is also something that is very important. So the team, again, there is no limitation who can be in the team. The psychiatrist, psychologist, endocrinologist, urologist, plastic surgeon, OBG, dermatologist, and it could be any other person, including an administrator, including a layperson, including an NGO, including probably a representative from the group who can be part of the team, because the team brings in strength. The team also brings in clarity about what could be done and how it could be done in a much more transparent way. Psychotherapy, this is something that has changed tremendously in the last 5 years. So when there was a WPATH 7th edition guideline, if you all know, till now, there is no national guideline. But what we were following, even though there was no national guideline, both in NIMANS and in our institute and across this thing, is whenever a client comes, they will be assessed and they will be put into psychotherapy. Now in this WPATH 8th edition, there has been a tremendous shift. They are now saying that psychotherapy is not an absolute requirement. In fact, they are saying that if the client has been living, has a real life experience of the gender that he wants to or she wants to change to, there is no requirement for therapy because they're already aware. And that is also added by a lot of evidence that psychotherapy has not really helped for people who are already in that space of transitioning. So it is no more an absolute requirement. This is something that has just happened few months back. Again, we might have to change the way that we are practicing, because till now what we were practicing is 1 letter for hormonal therapy and 2 letters, one from a psychiatrist and another from a psychologist, or 2 letters from 2 different mental health professionals for anything to do with the surgical intervention, because surgical intervention is irreversible. But now the recent evidence and recent recommendation says that psychotherapy is not an absolute requirement, no fixed number of sessions, and psychotherapy can be personalized predominantly to address the comorbidity, predominantly to address certain factors that might be influencing the transition. Follow-up sessions are something that is generally advised because the distress associated with transition is also something that we have noted over a period of time. Online and e-therapy. Medico-legally, online therapies and e-therapies do not have a very strong foothold. So what we practice as a principle here is we do not do online therapies for any of the transgender clients. So we only say in person, because many times there can be issues with online therapies. Family therapy, I would say if there is a family, if there are family members or friends or relatives, that is must and should, because that adds a tremendous amount of strength to the transition, and also the client will be able to transition in a much better way. The goals are to predominantly explore the reasons for gender dysphoria, explore the consequences because of the gender dysphoria, address stigma and minor issues. In fact, there are groups among the transgender population who have the list of professionals who are gender friendly. So in that sense, a lot of stigma is also expressed to healthcare professionals. So we need to address that. We need to make it appear normal, make it feel that they are comfortable, and address those minor issues. And also many a times you might be the first person whom the client has contacted, or you might be the first person that the client has come out to. So in that sense, we also have a tremendous responsibility to help them in the coming out process to and how do they do it? How do they say it? Do they say it immediately, or do they do it in a stepwise pattern? And that is something that we facilitate, and addressing the comorbidities irrespective of whatever that might be there. The certain aspects that are very, very critical to think about and keep in our mind is there is no strict timeline. We, in our institute, we have given letter as early as 2 weeks to 4 weeks, and sometimes we are not given the recommendation letter even after 2-3 years. That is depending upon the awareness, the acceptance, the clarity of the gender incongruence, depending upon various factors. And it is also as per the confidence of the treating team and convenience of the client. Letter of recommendation is preferable. It is not a certificate. Something which should be very, very clear is it is not a certificate. We are not going to certify. We are only giving a letter of recommendation for the treatment. And that is something, there are certain patterns or templates that we follow, which I would probably share after the meeting with all of you. And sometimes this is again a bit tricky. You can ask for an affidavit if at all you feel that there is a bit of medical legal issue involved. The client can self-declare with any lawyer or any notary and provide you a letter which you can use it for your documentation. There is also a Government of India website to help these people get whatever help that they would want. So we have also been encouraging people to register in that website, get a number so that they can have benefits at a future date, and there are certain benefits that is given by the government at this point in time. So we try to use that so that there are certain strong case for any form of medical legal aspect, if at all it is there. And we should be very, very careful about these things, because even 1 out of 100 is going to be a very, very complicated phenomena. Involvement of family and documenting the same in the file, identification and legal aspect. What we also do, irrespective of the name and the gender, we also collect certain identification documents like an Aadhaar or something. Again, that is for medical documentation, so that Aadhaar card doesn't change, so they are the real people that we are talking. We have also seen people who claim, who give us wrong numbers, wrong addresses, wrong names, and they vanish off after you give a letter. So we need to be careful, because sometimes those things can be tricky. The second aspect is sometimes they come with the same explanation. They already know what you're going to ask. They already know what you need to say. Sometimes that those things can happen. I'm not going to say it's common, it's rare, but we need to be watching out for those things, because those people might require much more help than people who are very, very clear in terms of the transition. So the other responsibilities as mental health professionals is legal in terms of name documents. Now it has become much, much easier. They have to just declare, and the gender changes. Previously, it used to be written as transgender. Now it is just written as male and female, depending upon what they would prefer. Education of individual, family, and society, peer support, and a referral. And this is something that is a strength of this group, where the peer support is not just amongst the professionals. The peer, they also have a peer support. There are certain groups which are very closed because of various problems, so they have a very close net group that they involve with, and we can also get into that group, educate them about practices. And there is another aspect of disorders of sex development, where there is a biological component which adds to it. So we need to be ruling out those things. A detailed general physical examination, detailed psychological evaluation, including corroboration and looking for consistency. When you see them multiple times, you will be able to pick up those consistencies. And the longer we see, better it is in terms of the information. A single slide about adolescent population or children. We are seeing people less than 18 years who present with gender incongruence or dysphoria. So according to a study in 2015, it is 1.2% and up to 2.7%, and can have gender diversity expression. So because it's not consolidated, it is not very strong, it's very, very difficult to come to a conclusion. What we do, what is accepted across the world, is we do not provide any transitioning during that time. What we do is fully reversible puberty delaying blockers. That is to help the body to transition at a much better pace, in a much better level after they turn 18, when they can give the consent. So we commonly use puberty blockers. We take the assent from the client, and we also involve the family members, take their consent, and we use puberty blockers and partially reversible hormonal therapy. So that is the only thing that is allowed in adolescent. Anything else, is any permanent non-reversible thing, is not allowed. And we also provide in terms of the support, in terms of the psychoeducation and any psychotherapy that the kids require. So coming to guidelines, this is probably the third and the last part. So there are various guidelines. Something that my talk, and I would also recommend all of you to go back and read, is about the WPATH guidelines, which started somewhere in 1979, and we have a recent 8th edition in 2022, Standards of Care for the Health of Transsexual, Transgender and Gender Non-Conforming People. This is the 8th edition. This is freely available. Anyone can Google it. Please download it and then you can go through all the terminologies, recent developments, and what has happened in terms of the changes that has happened and the evidences that is there. So there are certain other guidelines. Again, we do not generally refer to it, just for theoretical purpose. There is a blueprint for the provision of comprehensive care for trans people and trans communities in Asia and the Pacific. Is there any question? Yeah. So the other one is something that is there in Kolkata. It was published in 2017, a good practice guide to gender affirmative care. These are good reads. These are books which gives us a lot of information about what was happening at that point in time. Very recently, Nimans also brought out a manual in 2021 about transgender persons in India. Because this is very, very dynamic, it is very important to keep abreast of the latest thing, which is the WPATH 8th edition guidelines. So summary of the criteria for adults is always listening with professionals from different disciplines within the field of trans health for consultation and referral. We have had instances where we have even referred adults to Thailand or other countries where there are a much better skills, much better this thing. India, a lot of surgeons are now practicing it. We are seeing much better surgeries here. But sometimes some people want to go out of the country. We even liaison with people outside so that they get what they want. And if a written documentation or a letter is required to recommend gender affirming medical and surgical treatment, only one letter of assessment from a healthcare professional who has the competency and assessment of transgender and gender diverse people is required. So this is a big change in WPATH 8 guidelines, which says two things. One is the terminology of JAMSTT, and the second one is one single letter from a healthcare professional. It has even removed a mental health care professional, so who has the competency, because the WPATH also has yearly conferences, yearly training for everyone who is interested in transgender health. So those people also can provide a recommendation letter. For the hormones, one is the gender incongruence, which needs to be confirmed. They need to meet the diagnostic criteria for gender incongruence and capacity to consent. If there is any other thing that might influence the capacity, we do not recommend hormonal therapy before the management of those things. And any other possible causes of gender incongruence should be ruled out. Mental health and physical health conditions which can negatively impact should be assessed and taken care of. Like, for example, if someone already is having a lot of hormonal changes, they might not be able to take hormonal therapy because there might be an interaction. So they also need to understand and consent for the gender affirming hormonal treatment. The same is the case for surgery. This is something which we do after hormonal therapy, preferred, because you provide the hormonal therapy, prepare the body, and then go for an irreversible intervention. So they should be stable on their gender affirming hormonal treatment for at least 6 months. Sometimes I recommend for my clients for a year. So at least 6 months is required, where they would have handled a lot of things. Some amount of hair growth pattern would have changed. The voice might have changed. The fat redeposition might have been different. So they also feel much more comfortable and ready for the surgery. The limitations of the guidelines are predominantly because of the data, which are limited. They do not have data from across the world. There are data predominantly from the developed countries, not so much from developing countries. Variations, limited research and training, absolutely very, very less from the Southeast Asian countries and India, which is predominantly healthcare centered, which is not under the social construct. It is predominantly the healthcare centered, and there are specific certain timelines that are mentioned. India is a very special case because, one, we have a huge number of population and the proportion of people are also high. According to one data, again, that is not confirmed, Bangalore and Karnataka has anywhere between 1 to 1.5 lakh of transgender people. So that's a huge number, but what we see is a very, very less number. So there is no real accurate epidemiological data. That is something that is required. There are mental health professionals as it is very, very limited, and people who are aware, people who are confident of dealing with these things are much, much less. So limited training or no training, and making family as an active part, because family becomes a very important part. Most of our clients who come are not with the family, whereas in Western population, the system takes care, the family takes care. Financial issues, which leads them to risky behavior. We see every month at least one or two who would have gone to a person who has not been trained. They would have gotten surgery with no documentation, no legal support, no medical legal protection. So we know that even in Bangalore, there were instances where people were doing surgeries without any form of training or expertise. And private versus public hospital, the government hospitals uh, are yet to take up this cost. Predominantly the private hospitals are where all the things in terms of the team approach is something that is being practiced. So it requires a very special approach in terms of India. We might require a national policy for it, which is something which might happen in next few years. Challenges to the healthcare professionals is predominantly in the diagnosis and management, training, and support from fellow health professionals. In fact, one of the experiences that we had is surgeons were not ready to operate here when we said that this person requires a cosmetic surgery or something. So they were very, very reserved in terms of, oh, I'm not going to operate on these people. So support from fellow health professionals are very much required. Shortage of non-mental health professionals to take up this cause. Coordination and institutional support is something which is very, very important. There are certain places where, as it is, this is not being done. Stigma and legal and ethical challenges. What is the support that the institute will provide if at all I practice as my own interest when the institute is not supporting? So those are the challenges to the health professionals. When there are challenges to the health professionals, there are also challenges to the clients. So most of them do not know where to go, and that is one of the reasons why they end up with people who are not very qualified or who are not having an expert in this field. There are financial challenges where they might approach few quacks for the surgery. We have heard people getting surgery for as low as 2,000 rupees, 1,000 rupees, with no anesthesia, with no aseptic precautions, and people even having complications and losing their life. So financial aspects becomes very, very important aspect. The institute support to provide high concession is something which is important. Logistical issues. We have seen a lot of clients shifting from Mangalore, Coorg to Bangalore because everything can happen here. So many a times when they are unable to do it, that creates a problem, increases the dysphoria, increases the psychiatric comorbidity. Confusion regarding certification. Some people still continue to call it a certification. It is no more a certification. So in fact, today I had a client who said that they would want a certificate, even though surgery is done, hormonal therapy has been done. She has been living like a female for last 20, 30 years. She wanted a certificate. So that amount of awareness still should be there. The government has made it a bit more easier now. It's always important to approach and change the gender without actually having the certificate also. Affidavits and lack of other specialists in terms of who would do the surgery, who would do the plastic surgery, who would do the cosmetic surgery, those parts of it. Those are the challenges to the claims. I will skip this part because I've already explained why there is a requirement for India specific guidelines. A specific emphasis need to be given for training. This is something that we see that people, it could be residents in a training institute, it could be the psychology students, the awareness is much, much lesser. The training, hands-on training is much lesser because they are considered as risky population. The students do not get to interact, and this thing, that is something which can be important. And there can be gender teams in all hospital who take care of these things. There have been some efforts in India. IPS has a task force of LGBT, which is trying to work on a guideline. There are multiple CMEs and workshops at Nimans, Victoria Hospital, and with the group. In fact, we had to go to the place that they stay to provide awareness. So in that sense, there are multiple efforts till date. What we do at Ramaiah is something which has been established over the 10-year period. So we have a committee comprising of all these specialities. There is a chairman to the committee, there is a secretary to the committee, and there is a representation from the transgender group, and there is a layperson, there's a lawyer, and there are multiple this thing, just to in the created in the model of ethics committee, so that we understand the challenges, we help the clients as early as possible. They can walk into any department in Ramaiah, any hospital. We have 2 hospitals. They can come to any hospital, any department, and they would be directed as the first step for evaluation in our department. And once we roll out other comorbid diagnosis, or if there is any other problem, we provide a letter of recommendation, and we also talk to the person whom we are referring to. Hormonal therapy and follow-up happens with the endocrinology department. We have a surgical team which is quite well versed with the surgical intervention. And sometimes if the clients are not very comfortable at getting the surgery done, we cannot force them to get the surgery done in the same place. So they can be referred outside, including out of the country. Follow-up and booster sessions are something that we have seen really helps, because they think that the transitioning is something that's going to completely change their life, which is not true. The transition happens in terms of physically, in terms of acceptance, stigma, there might be certain issues. We continue to help the client to deal with those stigma, deal with those challenges that come. So booster sessions are something that is recommended. Medical legal support and guidance in terms of issuance of the letter, either sometimes for the name change, because many a times in the remote part of the country or Karnataka, they might not be aware. So we provide letters to educate and also say that this person requires these help. This is what we do, and we have been doing this work for the last 10 years. And there is a good team who understand, who support each other. And the committee was just done few months back, because we felt that that is required to formalize the whole arrangement. So the recommendation is almost parallel to what I said. Initial psychiatrist or a psychologist evaluation and diagnosis, referring to the psychologist if therapy is required. The word is very, very important, if needed only, according to the newer guidelines. Dynamic timelines and assessment. We don't have to, there are instances where people have come and said that, okay, we were told that I can't get a letter for 2 years. No, that is not the guideline anywhere. So depending upon the individual factors, the timelines can change. Recommendations letter, wherever that is recommended or needed, in terms of a hormonal therapy, in terms of the surgical intervention, or it could even be for a medical legal purpose. So we provide those recommendation letter. Constitution of multidisciplinary team. It gives strength when there is more than one person. So always having this team who can support each other. Follow up even after the hormonal therapy and surgery, including individual therapy. Role in the legal changes in terms of again, affidavit or name change or gender change, those things. So this is something, again, this is not published data. This is something that we did just to emphasize that when we provide adequate support, what happens to the quality of life, because this vulnerable population is considered as one of the risky population because of the comorbidity and the quality of life. So we did this study a year back where we evaluated 25 trans men and 9 trans men. 34 is the population. What we saw was the gender expression was very different, because the acceptance in the community and society is very, very less. So full-time were only around 60%. So another 40% were following part-time expression, where they would dress themselves as the gender that they would want to in private, but outside they would be expressing the gender or the sex at birth sort of thing. So that is something that is very important. This is something that is we were really happy and shocked at the same time that a transition is going to make such a big change in the way that they look. So we evaluated their quality of life under 4 domains: physical domain, psychological domain, social domain, and environmental domain. you can see that between baseline and 3 months and 6 months, the p-value is so significant. So that means that any intervention, psychological and surgical intervention in this group, is going to make a tremendous shift in their quality of life, in the perception of themselves, as well as the comfort in leading the life as any other person in the society. So if I have to say one thing, it is the understanding, providing support, and a continuity of care, which will create a major shift in their quality of life, and we should all aim to do it. So this is what I wanted to present, ending with the data that we have. Again, that is not something which is published. I'd be happy to share the data if someone is interested to have a look at it. So I'll stop here. I know that it is a too much of information. I'm not sure. So please feel free to unmute yourself and ask me anything. I think whatever questions that we had before the session, I've tried to address it. If there are certain things that you would want specific clarification, specific inputs, please feel free to ask.
Thank you so much, Dr. Virupaksha, for such a comprehensive talk today. I was also thinking about how relevant this presentation is in today's world. I had a couple of thoughts. I was thinking, I was wondering how the way you took us through the important terminologies was quite relevant for us. And it was also interesting to see how you defined non-binary and gender fluidity. I mean, these are things that we should be aware of, and it was quite relevant. And I also was thinking, I wanted to appreciate you on the way you showed us the referral pathway, because I think it often becomes useful, because there is a slight hesitation in mental health professionals as well. Questions like, are we equipped? Are we trained? Are we understanding enough of their experiences? So that was quite useful as well. Finally, I was also thinking of how important a multidisciplinary team is for the mental health of the transgender community as well. So thanks so much for that. What I would like to do is, should we go over the questions? I think the first question that we got was in terms of any support groups or any other resources. You have answered most of the questions, like you said, but if there's anything else that you would like to add.
Yeah, so the support groups, I think in Bangalore, as I'm aware, there are multiple support groups. Something that is very, very important to understand. Also, these groups are very close groups. There are specific groups depending upon the transition, depending upon the gender, depending upon the language, those things. So I might not be able to share the details here. So what I would also suggest is, if someone wants information about those groups, probably write it to me or message me. I'd be able to share bilaterally about those things. But there are lots of support groups. What I should also warn is, there are certain groups which are a sort of open group, where we have also heard some amount of bullying, some amount of other aspects that can happen. So you should be very, very careful what group that you have to get into. So like for example, there is a very close group of gender minorities within IASC, where they discuss a lot of things. There is much more awareness. They bring out the challenges. They try to seek help for those things. So similarly, there are groups who have certain issues with orientation. There are groups from male to female, female to male. So I would probably share it bilaterally if that is required. But definitely there is a support and a very vibrant supportive community that is there out there for anyone seeking help.
Right. Yeah, I mean, that's quite interesting, but at the same time also it's quite disappointing to see that we have to struggle so much to identify these groups, because of the kind of bullying experiences, the kind of discriminatory feelings that they're supposed to undergo.
There were probably to just add why it becomes such a complex issue. There were instances where a person who is I think there was also a question about Jordan Peterson.
Yes.
So there are people who do not believe in it. I think this will continue to happen. So sometimes when these people get into these sorts of groups, there can be a very, very uncomfortable situation. And it is also quite demotivating. So in that sense, that is where I think the community is quite reserved to just open it up to everyone and anyone, because at least they need to protect themselves.
Absolutely, it's very well said. I'm going to move to the next question. In terms of, you did touch upon this, but it was quite an interesting one as well. How common is it for the transgender community to develop substance-induced psychosis? Wonder what's your take on that?
I'll probably answer that in two parts. One is, let us not look transgender community as a community where there is a specific vulnerability to develop psychosis. Number two, whenever there are certain vulnerabilities, just like how it can happen to any one of us, imagine that there is a stress, imagine there are certain things that we are dealing with, and we are not equipped with certain psychological factors to deal with it. So when that happens, there are ways where we might try to handle those stressors by using substances, which is again one of the common advices that a lot of people might give in this community. And substance use is something that is very common in this community because, you know, it has been normalized in them. So sometimes in some people who are vulnerable, they can go on to develop substance dependence, I would say addiction. See, substance dependence or addiction becoming psychosis is very, very rare. Just like how we see it as very rare in general population, it is also as rare in this community. So I would not put any special emphasis on substance use into psychosis, but there is a very high prevalence of substance use and addiction in this community. Something that I did not also touch upon is the aspect of the sex work. So commercial sex work, primarily because of the financial component, that most of the times the family would not have provided them support, or they might not have any other way, because whether we like it or not, the industry or the society do not employ them as easily as any other person. So they have difficulty in getting a job. So when they do it, something that as a community that they do is they get into commercial sex work, which is also something that puts them at risk for various sexually transmitted diseases and you know, in terms of other psychiatric comorbidity. So in that context, I think we need to be very, very conscious about those things. So there is a high comorbidity of depression, anxiety, and psychosis, just like any other population. But the vulnerability is about the support, vulnerability is about their coping mechanism, which makes them a bit more special in terms of the support.
Right. So what I'm hearing you say is it's more to do with the kind of support that they get in their upbringing, and even in terms of the social and environmental factors, how they were treated in terms of the schooling experiences. So those things become extremely prominent as well.
True.
And which, okay, right. So the next question that we had was, do you have any resources for better understanding of the emotional challenges that an individual goes through?
Yeah, I think one of the article or the resource that I would suggest is WPATH guideline. It is one resource which has touched upon everything, including your mental health, including the aspect of surgical intervention, those things. The second one is there are certain specific articles. Again, I will provide my email ID. Please reach out to me. I will send you those articles, including a study done in our institute regarding the comorbidity, what we could do, what is the sort of help that they would require. In terms of the psychological intervention, again, I would not make them very different from general population. So you assess them, see what are the concerns, and handle it just like how you would handle in any other client of yours. So there is no special intervention that is required for them. The only thing is we need to be sensitive, we need to be aware, and we need to use the right terminologies, because the distress can be just calling them with the wrong pronoun. So that itself can lead to panic attacks. I've seen clients going through days of panic attack because one person called them with the wrong pronoun. So that is the thing that we need to be worried about.
Right. So it's more important to make ourselves more sensitive, more aware, more accepting of their, requests, their, yeah. Right.
True, because we can't call them as patients because they are not patients.
Of course.
So
Absolutely.
and we cannot call that as certificate, and we cannot call it as a disorder or disease. Sometimes because we are used to it, we might blurt out something. So it's important that we need to be we are aware and be careful.
Thanks so much for that. And I really like the way you phrased it, where you said, let's not treat them as a very special, or in the sense, completely different community. Treat them the way they expect us to treat them. All right, moving forward. Yeah, I think this is one thing that even I was wondering, what are possible risks involved in, gender affirmative surgery?
I would say probably as equal to any other surgeries, because this is just another surgery which is done, especially if it is done with a qualified professional in a hospital under aseptic precautions. The risks are very, very, very minimum. I think we have not seen probably 1 or 2 out of 25 or 30 surgeries where they had some infection. Other than that, most of them fairly recover well. There is absolutely no problem. And most of the times it is the post-surgery which is important. So where there is some moment of reconstruction that is being done, if it is male to female, there requires a dilatation, vaginal dilatation over a period of 4 to 6 weeks, and continue to do it. So those things are the thing that actually determine how good or not so good the transition is. As it is, because of the surgical process, most of the times it's based upon the aseptic precaution and the skill of the surgeon. If these two things are taken care of, the risks are very, very minimum as a minor surgery. And we know that any surgery has certain risk factors in terms of anesthesia, in terms of surgical intervention, those things which can only be noted once they are on the table. Otherwise, I have not seen anyone having any major issues, and I have also not seen in the last 10 years anyone having a problem with their life or losing their life post surgery. In fact, their quality of life and including the immunity and health has improved post surgery.
Right. Thank you so much for that. I think a lot of us wonder about the same thing, and I think that was quite useful to know as well. Now, the next question, I think you've already answered, role of a psychologist and the limitations in the procedure as well. I think a lot of other people also want to ask a couple of questions. I'm going to move a little bit more quickly. So what are your thoughts in terms of how to plan your work on fluctuations of gender dysphoria throughout the day? I'm not entirely sure if that's
yeah, I'll answer that. I understood the question.
okay.
So the most important, something that I have found to be very helpful is to in the first instant, you tell them that, okay, the journey is going to be bit inconsistent in terms of there can be ups and downs, there can be fluctuations in their mood, there can be certain chaoses that they might experience in between. It could be because of external, internal, hormonal therapy, family interactions, or probably acceptance at the workplace or their college. So we already know that the journey is not going to be very, very smooth. So I expect that next time when the client comes and sits in front of me, he or she might say, I've had a bad day. I already know that he or she might have had a bad day. And because I already warned this person that, see, it's not going to be easy. There will be issues. Yes, because your family has not accepted fully, doesn't mean that they are going to be always calling you with the right pronoun. Sometimes they might do something else, or sometimes what I've seen commonly is family is dealing with their own stress, and then they are going to say it's all because of you, and that can trigger something. So you make it a point to express or explain to the client that the journey is going to be tumultuous or a bit more rocky, and that will also help them to express and tell you whatever they feel. I've had people who just message me in the middle of the night saying that I'm going through this, what to do, and all those things. Just a message from them is something that will reassure them. Personally, I'm quite comfortable in sharing my email ID and phone numbers with my clients. Many people do not do it. If that is the case, always give them someone or some contact who's going to just say, you're going to be fine, don't worry. So they just require that reassurance to start with. And then, as in when you have probably have met once or twice, you will invariably understand what are the specific challenges to these clients, and then addressing those issues. We have had one example that I can give you is there was a client who's a very bright student. Parents are highly educated, working population, a lot of presence in the society. They had difficulty in accepting it. They, even though they accept it here, once they go back home, you know that whenever there is no neutrality, they tend to express few things. So we prepare for all eventuality. We tell them that, okay, there is someone who can talk to you and help you out to understand it in much more clarity and provide that continued support. Unfortunately, just a session of once a week or once in 2 weeks generally has not worked in this population. They reach out to you in between, or at least they have a person whom they can talk to. So I would say that is how we could help them. And that is also the reason why, if there is a team approach, that will help. Something that we do in Ramaiah is, if they can't see me, they can see an endocrinologist, because endocrinologist is already seen. If they can't see endocrinologist, they can see our plastic surgeon or a neurologist, because we don't even make them to open the file. We just say, the patient comes to me first. I say, have a chat with the endocrinologist, have a chat with the urologist, have a chat with the surgeon. So they know that one or the other person is always there. And that projection of the team brings in a lot of positivity, and that gives a lot of reassurance also to the client.
Quite useful to know the way you've described a multidisciplinary team should be working with a client who's coming to you with such difficulties. That's something we don't see very often, do we? Go to this person, go to that person. That's something that has really stuck with me today. I would like I think Dr. Sai Kumar had raised his hand. I'm just wondering if Dr. Sai Kumar, do you want to? Yeah, thank you.
Can I?
Yes, please introduce yourself.
Am I audible?
Yes, you are.
Okay, thank you very much for the opportunity. I really appreciate the speaker who has been very eloquent in the details about it.
I think
sorry,
there's a signal issue.
Yeah, sorry, there's a disturbance, Dr. Sai Kumar. He's also put up a lot of resources on the chat. Maybe we'll give him a couple of minutes and get back to him. Purnima, do you want to unmute and ask your question?
Yeah. Hi, good afternoon, Dr. Virupaksha. Thank you for such a comprehensive and informative session. So I'm a clinical psychologist, and my questions are arising from my short stint working with this population. So I will be having a couple of questions for you. So the foremost is one of my experience working in the phase of giving a letter or that certificate to a client who was coming from Canada and had come to NIMHANS and was assessed by both the psychiatrist and me, and the certification had to be given for the HRT. So I wonder that are there any intercontinent kind of a rules and regulation that apply, or the WPATH guidelines are enough to issue those certificates, and how much real life testing period is applicable in India per se for to give them that that certificate for going for the HRT and reconstructive surgery?
Right. Thank you so much for those questions. I think I'll answer the first one. What we have been following from the day one of the issuance of recommendation letter is the WPATH guideline. Because WPATH guidelines is widely accepted across the world, they cater to the global professionals of working with the trans health. So we have issued, I think, to more than probably 8-10 countries in the last 5-6 years, where they have gone to be it in Germany, be it in Thailand, be it in US, in Europe. So generally there is a format. So you give that letter. There are certain basic details that are required. Who are you? What did you assess? When did you assess? What did you rule out? Whether there is any other comorbidity, whether there is any lived experience, whether there is any family support. Did the client come out or has a coming out process? And any requirement of treatment, and do you feel the person can go for hormonal therapy and surgery? So if we include these details with clear information about what you are, with the sign and seal with the institute letterhead, I have not seen anyone having any issues outside. In India too, we have not seen any problems, but outside India also, we have not seen any issues. When it comes to the lived experience, that is where the discretion of the clinician or the person who is evaluating comes in. So if they've had no lived experience and we see that there is still a confusion, they're at the confusion level, they are at the distress level, they are not very comfortable in expressing their gender diversity, that is when we slow down. We say, take it for another few months. And again, we do not define a particular timeline, because we have seen sometimes in the past, in the beginning, you say 6 months, they do not come for 6 months. And 6 months later, they are sitting in front of you and say that, now you told 6 months, I've come after 6 months, give me a letter. So we continue to see them every month or every 2 weeks, either a psychiatrist or a psychologist, and including they also drop into other specialties. And when you feel that the person is comfortable, and that is also something that I've seen, and you can also feel that comfortable factor, that that, okay, you could easily give the letter for hormonal therapy or surgical, that is when we do it. It is very difficult for us to specify what should be the experience as the other gender, because in fact, in the previous guidelines, they were saying about timeline. The timeline is absolutely something that should not be there. It is not being followed. In the newer guidelines, they have taken it off everything. So depending upon your discretion, depending upon your confidence that you have not missed out on anything, you're clear about the expression, you're clear about what the client wants, you can issue the letter of recommendation.
Right. Thank you. So like, I'm just trying to clarify certain things. Like, when we talk about lived experience, which includes like, them using public toilets for at least 1 year, of the opposite gender, and at least cross-dressing like that. So do we make it mandatory, or do we ask them to do it when we are issuing the certificate?
We tell them it is preferable, not because it is mandatory, because they need to know what are their experiences. They need to know what they will go through. So as someone goes to male to female, goes to a female toilet, what are the stays that you're going to get? What do people tell you? What will you tell them? How will you feel? If you have a panic attack, what will you tell yourself? So it is predominantly from the aspect of intervention. It is nothing to do with being mandatory. In fact, we cannot make it mandatory. Because they are free to express and use it. And yes, there are instances where people have told it as mandatory, which is again not medical legally covered for us. So you can always say that it is preferable that you have these things. And if you feel that the person is not really ready, you can always buy time. You can always say that we want to spend some more time to discuss these things, because we expect that your transition might be, it might be difficult, or you might have certain issues at a later phase because you do not have experience of handling the routine things, including the aspect of stigma, including the aspect of bullying or acceptance for that matter.
Right. Thank you. One last question, please.
Please.
So I just want to check with you, what is the importance of psychodiagnostics? Like I'm talking more in psychometry, because a lot of clinical psychologists, and at one point of time, including me as well, were made to do certain diagnostic as to, as a supplement to before issuing that certificate. So I want to know what is the importance of those things and how much legally it is important.
Two aspects. One is, especially if you are doubtful what you're dealing with, that is where these things come into the picture, psychodiagnostics. So if when you have clinically evaluated the client, you're very clear what's happening, there is information, you could corroborate the information. Probably, I think our referral to psychodiagnostic is less than probably 1% or less than that. At some point in time, because the government was not very supportive and there was less awareness, there was a lot of medical legal issues, including in Bangalore. In the last 5 years, we have had 2-3 major issues that happened. So I think we were into a very defensive thing where we were trying to get as much information to support our diagnosis. So if the clinical diagnosis is very clear and if you have everything that you have documented, and this thing might not be required. Again, medical legally also, it is not something that is a requirement. What would happen if we do it? I don't think that's going to damage anything. If you do it, there is no harm. If you do not do it, especially if you're not confident, then there might be a minor medical legal aspect there. But doing it as part of this thing, I would say it's always left to the discretion of the clinician and the institute, because I still know that there are certain places in Bangalore where these things are done as part of a normal assessment. Do we do it in Ramaiah? No, we do not do it in Ramaiah. And is it recommended? No, it's not recommended unless you have a diagnostic confusion.
Right. Thank you so much. Those answers were pretty helpful. Thanks.
Thank you.
Thank you, Purnima, for raising such important questions. Dr. Sai Kumar, do you want to come back in? Sorry, we lost you that time. So
Got disconnected because of the 2 questions I had asked. One is that the minimum age that you can recommend that therapists can encourage them to think in those lines, other than the legal eligibility. The second thing is that your experience of dealing with practice.
Sorry, sir, I didn't get your second question. Can you please?
How do you deal with that, and as well as what are the issues that you see as a convenience or comfortable or no in order to help the clients, either for the public health or perspective model or private practice model? Because people who are even can't afford, they have to go to the public health, but they have got challenges there to do that. But when they come to the private practice, they have to pay and then get it, and there are other issues that are also involved. The constraints of legal and other things. So how do you look at it?
I'll answer the first question, sir. Even though the second question, I have a bit clarification. So I'll answer the first question. So there is no minimum age for support. In fact, the youngest client that I've seen is of 6 years. So we support them, we educate the family, and we wait. When there is a puberty onset, we can give puberty blockers if we are very clear about the diagnosis, and then at the age of 18, they can take the call about the further transition. So there is no minimum age criteria for any form of support from our side. The second question, I could understand partially because first half you're not very audible. So whether they can go to private or government, again, like you have mentioned in the chat, Tamil Nadu has been quite progressive in terms of support, inclusion, including, I think there was a superintendent of police from a transgender community, and that is something that is commendable and a role model state for all of us. So in Karnataka, what we do is, because our the psychiatry, the professionals of psychiatry is a very close-knit community. What we also do is sometimes when they are unable to take help from the private hospital, we talk to the person who is there. Like, for example, in Bangalore, we predominantly talk to people from Victoria Hospital. We ask them whether they would be able to help, give them a background, what they would require, and all those things. So they are being quite helpful. So, like, for example, in Nimans also, a lot of psychological intervention and recommendation letters happens there, but the surgery should happen somewhere else. So multi-institute collaboration and cooperation is also something which is very, very important. And what you raised is a very important point, because sometimes we cannot expect them to have all the financial support that is required for transition. So at that time, we tend to maximize the opportunities. In our institute, any sort of help that is required and intervention to transgender group is at a highly concessional rate. In fact, I could say that it's almost free, because this has been happening for a really long time. Over a long period of time, it has been done as a concessional treatment. So if the private institutes also can probably dedicate a part of their service as this thing, this population might get help.
Is it covered under insurance?
At this point in time, all insurance companies do not cover it. But now recently, there are certain insurance companies which have changed their underwriting. So you have to specifically ask them for coverage. Your premium is a bit higher, but they are covering both. I think the same thing. I'll also take this opportunity about mental health insurance. So mental health aspects are also covered under insurance now, but you need to specifically ask for it. The premium is a bit higher, but now some companies or some insurance companies have started to cover it.
Thank you.
Thank you, sir. Thank you for these questions.
Yes, absolutely. Thank you so much, Dr. Sai Kumar. You've also put in some resources which I think could be very helpful for us. I'll move forward to Kavita Hariharan. I think you had raised your hand. Would you like to ask the question?
Hello, good evening, and I'm a counseling psychologist and I'm also a sexual health educator. I, in fact, raised a thing about Jordan, right? So he's a very well recognized person in terms of, but there are so many people who follow, and this brings a lot of dilemma in the minds of people who think they are, very diverse. I mean, at least they have this inclusive mindset kind of a thing, right? So that brings a lot of questions in terms of understanding how things happen and stuff. That aside, I just have one question. Do we have a lot of research studies to understand whether people are really happy after they have, undergone these hormonal things and, the surgeries? Are there real-time studies, at least within India? I know there's very minimal in terms of research studies. I think across the world, if we compare, there are very minimal research studies that happens in India. But as such, across the world, do we have any research studies and results? Are people really happy after all these, things?
Yeah, I think that is the most important question, because that is what we are all aiming for, whether people are happy post transition. Western studies have consistently noted that post transition, the comfort, happiness, and quality of life improves. With whatever understanding that I've had and the literature review that I've done, we have done a study in Ramaiah, which is yet to be published. This is one of its first study, which looked at pre-post assessment of quality of life, their mental health issues, including the anxiety, depression, psychotic symptoms, and the support perception, family dynamics, those things. So I have not come across any other study from India which has looked at it. So probably if you can just mail me, I will share some details that we have collected. Again, not for free circulation, because it is not yet published. And answering to that question, there is a tremendous change in their quality of life and their perception post transition. So almost everyone was happy after transition.
Thank you so much, sir, because I get this question very frequently. I usually visit schools and I conduct workshops for parents as well, in terms of making them understand what all these means, the terminologies especially. Parents are very concerned about why do you give ideas about all these things, because I personally think that's when you have to give clarity, and the adolescence is a time where especially majority have developed their own sexual identity and gender identity, right? So uh, to tell them that it's not confusing, at least to but parents are concerned and they ask me such questions. I myself try to get some answers, but research studies I wasn't able to get the results, so I thought I can check with you. Thank you so much, sir.
Sure. Thank you.
Thank you. Mrs. Priyanka, you've asked a couple of questions on chat. Would you like to unmute now?
Can you hear me?
We can, but there's a lot of disturbance in the background.
Okay, is this better? 1 second. Is this better?
Yes.
Okay. I wanted to understand how would a medical doctor be qualified enough or equipped enough to provide this recommendation letter and to understand the whole process? How would we know that?
Okay. Thanks for that question. I think the training is the most important thing as part of the curriculum. If at all you're already practicing, you're already a clinician, the best thing which I would recommend is WPATH has this training courses once in 6 months, and also probably work with other people who are working in this field. In fact, when I started working in Ramaiah, I had absolutely no training in these groups, because in NIMANS at that point in time, we would not see, I hardly have seen one or two, I think. So there was no formal training in that sense. So over a period of time, there was a urologist who was doing surgeries for a really long time. So we got along, we learned a lot, we went to the community, we spoke to them, we understood their requirements and all those things. Now there are already multiple groups in Bangalore who are working, so probably interacting with them, seeing some clients, interacting with those clients, and doing a formal training which is done by WPATH. As of now, WPATH does these certificate courses in trans health. So that is one way of getting at it. The second one is doing it in a group which is already practicing or already working in this area. I think that those are the only two ways that I can think of.
Sure, sir.
Thank you.
So the other thing is, so this was about medical professionals. So how about mental health professionals?
Yeah, I think both applies. The same explanation applies here. Only thing is now there is a difference in terms of lot of mental health training institutes are now focusing upon gender minorities and transgender mental health and these things. So awareness, I would definitely say that the students now are much more aware than what it was happening before. Yes, it requires strengthening, it requires support from senior staffs and all those things. Yeah, that is something that can happen, and that is also a limitation in India at this point in time, because there is a very less number of people who are well versed with terminologies and the techniques in dealing with transgender mental health.
Does WPATH have the professional training, like what you said for medical?
Yes.
Same way, does it have for mental health as well?
Yes, it has for mental health professionals. It has a separate training. It has for other medical professionals, and it has a specific hands-on approach which happens in different parts of the world for surgeons. So it has 3 different trainings that happens, which are announced in the WPATH website. Yes, so if you become a member, it is in under some concession. So they have a yearly conference, which is quite a big conference. They have a yearly conference, they have training and all those things. I would suggest that if there is a specific requirement of training, that would be a best place.
So last question is, how do we reach out to you? Your number and email ID, please. If
I
you could
will just put it in the chat box now. So
sure, sir. Thank you.
excellent.
Very helpful, sir. Thank you so much.
Thank you so much for
deep
this
dive.
question.
Thank you so much, Ms. Priyanka, for your questions. We also had another question on the chat by Kanchan. I'm not sure if you're here. The question was...
Yes, I'm here. I thought it's too late and I didn't want to I deleted it. But, to bring it on, I've had one or two clients where I do adolescent counseling, where the kids are very sure that, they feel like that. And we've had various discussions on that. But constantly the parents are in denial. And they are not willing to support the whole thing, obviously financially as well, and emotionally, and also not willing to even, go through the process. And, I've had this kid who started going to a doctor himself, and he started to have the medicine, the puberty, this thing
Blockers.
to blockers for this. But, the mother threw away the medicine. And so, it's just like, is there any particularly strong thing that you think that would help the parents understand it in a better way?
Two things that has helped, again, it comes with all the challenges that you mentioned, is before we do anything or less than 18 years, we say that at least give us an opportunity to talk to your family. So continue to talk to the kid, continue to talk to them, educate them to talk to the family. Two advantages. One is family is going to believe the moment you talk and say that you are very, very important. They feel included, that in the decision and in the process they have been taken into account. The second one is you also get an opportunity to educate them. So when we take a sheet of paper, explain what it is, explain how it is, and what they should do, what changes and what doesn't change.
Right.
Most of the times, yes, we have taken the maximum that we have taken to convince a family is 3 years. So 3 years, the client was waiting. So, but when we make it a point that, okay, we are waiting for you to come with us, because the journey has to be together. The family always starts the journey a few kilometers behind. So we need to stop there, wait till they reach us, and then take it ahead. I think it has worked most of the times. Like all disorders or medical aspects, we will have certain aspects where we won't be able to do anything, but it works most of the times. And we've had one client from Kutch. So the parents came down to Bangalore. They put it in a very nice way. We came with the daughter, we are going back with the son. So sometimes they have this their own mechanism, but they require time to accept. They require support. And like I said in the presentation also, they require more support than the client, actually.
Yes, that's so true. That's exactly what I've been feeling. But sir, is there, in your sense, it has, I'm talking about in generality, that you've mostly seen that the pair, because at the end of the day, we want it to be a happy family, right? True. But mostly you have seen that parents do come on board at sooner or later.
Yes. Again, we need to persist, we need to persevere. And they come reluctantly. Many times you have had families coming in, and I have this client whose family came in. The first statement that they said was, "Doctor, we know what you're going to tell. We have just come because you have been repeatedly calling. We are not going to change our mind." And this is probably a year back. Now the client is on hormonal therapy with some support from the family. They're not fully supportive, but some support. So I would say that expect that challenges, and I think this is something that is quite common in our field: resistance, acceptance, and all those things. That is where our skills come in.
Yes. Thank you, sir. Thank you. Really appreciate this. Thank you so much.
Thank you.
Thank you so much for that. I guess parents really have their way of surprising us after all. I think there's a comment by Dia. sorry, it's a question. Do you want to unmute and ask?
Good afternoon. Hi.
Hi.
Firstly, thank you so much for what you've spoken about so far. I'm learning so much. I'm a counseling psychologist myself. And my question comes from the place of, the previous question as well, where families, of course, can be very unsafe and very unsupportive spaces as well. It can go to the other extreme too. So in that case, what is a protocol when it comes to giving the client a letter? How
Right.
much of it is mandatory in terms of family support?
Right. So probably I'll answer that in two parts. The first part is whether family's journey is much more difficult than the client's. The answer is yes. The reason for that is family will bear the maximum brunt in terms of handling people, handling relatives, handling the society, acceptance, expression, and all those things. So what I have seen is family always has a much difficult journey. It is a bit easier journey even though it's again difficult for the client, because they are going through distress, and whatever transition that they are doing is going to reduce the distress. Contrary to family, as the person is transitioning, the distress increases with the family, because they don't know what they will tell, how they will tell the family members, or what they will do. So that is something that we make sure that the family is told about these things. They are empathized, they are supported. Sometimes even family therapy is something that is very, very important, should be considered. The second aspect is, if the client is an adult, it is not mandatory for the family support. And in fact, if the client says, do not contact my family, I'm not comfortable in you contacting my family, I do not want my family to be informed, no, we do not. We just documented that the client has reservations about contacting the family, and we still give the letter of recommendation. So it's not actually mandatory for the family's consent if the client is an adult. If the client is adolescent or less than 18 years, invariably the only treatment that can happen is puberty blocking, where we take the assent and we mandatorily take the consent of the family.
That makes a lot of sense. Thank you so much.
Thanks, Dia. Thanks.
Thank you. I guess we don't have any other questions coming in. Can I squeeze two of my questions in the meanwhile?
Please go ahead.
Thank you. So I've been thinking about this. What would acceptance and unity look like for mental health professionals? Because right now what I'm seeing is also a lot of divide in terms of how we feel as to how we need to treat. So what does that look like? How does unity look like for mental health professionals?
I think it's an ideal situation that hopefully we will have in next few decades. I'm using the word decades.
I saw that.
The reason for that is there are still, unfortunately, as professionals working in the, this is probably not the evidence, it is from the experience of interacting with a lot of people, is we are unable to, separate that, okay, our upbringing was like this, I believe in this, from the professional training and the scientific evidence that we have. So sometimes our own internal aspects and personality factors and all those things, when it influences our professional work, that is when the conflict can happen, that is when the distress can happen, that is when the acceptance also doesn't come in. So I still continue to meet people who do not think that this is a normal variation. They think that it is an abnormality. They think that this has to be treated. I still come across certain prescriptions of treating it like psychosis, and it's quite unfortunate. But I think over a period of time, the more people who are on board in terms of understanding, awareness, acceptance, and feel supported, I think the community is only going to become bigger and bigger in terms of and that is good for the science, that is good for the community, and that is also good for the transgender population. It's an ideal expectation. Hopefully, I think will not take decades. We should be doing it in a few years. Hopefully it happens soon.
Absolutely. My other question was, we're also looking, I mean, it's amazing how we spoke about families. I was also wondering in terms of the system change, the systemic change, what would be some of the economic, cultural opportunities for the community?
In terms of the again, when we talk about families and the systemic approach of the change, one is, I think, on a larger extent, we are going to accept variation as a normality, because I think that is something that is ingrained in our society and systems, that you have to be like this, you have to behave like this, you have to express like this. You take it from the social, personal, physical, academic, cultural, and all those aspects. So I think it's only enriching for people to understand, accept, discuss, and also accommodate these variations as part of the normal presence. And I have also seen how family they change the whole outlook of their own self, and that creates much more bonding within the family, and they also become like the ambassadors of change around them. And one of there are so many clients that I can remember of who are bought by families who have helped their family member transition. So it's like an umbrella. It's only going to expand and expand. And any form of, I always believe that any form of interaction or even a talk with a family member is always helpful, if not immediately, on a long term, because you're going to make that change in their way of thinking. The second aspect, one example that I can give you is, there was a very young client, no parents, but there are grandparents taking. Grandparents had a very separate this thing. So we have not reached anywhere. We are continuing to have a conversation, and you see the change and acceptance that they are doing, and how supportive they are. They are quite regular for follow-up. They are quite interactive and all those things. And that is what I think is going to be a larger benefit to the society.
Thank you so much for that. We have another question coming in from Kanchan. Do you think we have achieved the scientific medical excellence in this?
No, I personally do not think we have reached that. There's still a lot of things to understand in terms of awareness, in terms of intervention, any specific aspect that we need to do, and including predominantly at the level of hormonal and surgical intervention. I think we have not reached there. In terms of the support, our support from the mental health professionals is predominantly at the initial phase, preparing them and then helping them to deal with the post-transition. So it is still evolving. One of the prime example is the WPATH 8th edition is very, very different from 7th. So in a matter of last 10 years. So it is going to change. I don't think we can be confidently saying that, oh, we have all the information at this point in time. So yeah, we need to be open. We need to continue to keep abreast of the latest evidences, latest interventions, what helps and what doesn't help.
That's useful to know. Is there anyone else who would like to ask or make any comments? Okay. Yeah, I think we've answered all the questions that came in on the chat as well. So I would really like to thank you, Dr. Virupaksha. I think this has been such a good 2 hours. And I mean, there are comments coming in that saying great session. Thank you so much for this informative session. And I completely echo it. I think it's been quite eye-opening, because we as mental health professionals also don't indulge as much as we're supposed to. And I'm equally so thank you so much for this. It's been a very, very enriching 2 hours. And yeah, I would thank you on behalf of the
thank you so much.
Thanks
for providing the opportunity. It's always a pleasure to talk about these aspects and understanding and learning from each other. And thank you all for giving this opportunity. Take care, everyone. Bye-bye.
Thank you. I think we can close for today. Thank you so much, everyone,
Yes.
for being such a
Thank you.
good audience. Thank you.
Thank you, Dr. Virupaksha.
Thank you so much. Bye-bye.
Bye.
Bye.